Hi there. My name is Tarek Samour. I'm a colorectal surgeon at Royal Adelaide Hospital. I'd like to thank the organizers for asking me to speak today about robotic surgery. Um, by now, everybody's pretty familiar with the technology. So the way robotics works is it's the often regarded as the next step of laparoscopic surgery, where instead of having a human controlling the ports, it's actually a robotic device that is controlling the ports, and the surgeon is sitting somewhere off to the side, controlling the robotic arms. This uh, provides a few benefits in terms of better visualization, improved access, and improvements in terms of 3D articulation of the instruments. So why am I talking about this? I did develop an interest in robotic surgery during my fellowship. I spent a year in Houston at the MD Anderson Cancer Center. The person in the photo there is George Chang, who is an expert at robotic colorectal cancer surgery, and I trained under his guidance. MD Anderson does about 150 rectal cancers a year, of which approximately half are done robotically. The rest are typically either done open, or they are exenteration type cases, which minimally invasive surgery is not feasible for. And so I developed an interest during this time. In my year there, I did 40 cases, and when I came back to Adelaide, I started doing a little bit of robotic surgery. The volume that I have in Adelaide is much lower, and the access I have is largely for public patients that receive rectal cancer surgery in the private sector. The public hospital buys time on the private machine for us to do that, and we get a list per month to do that on, which is shared with one of the other public hospitals in Adelaide. So, in talking about robotics, I'm going to try and give quite a balanced talk in terms of, where the role of robotics is today, particularly for colorectal cancer. I'll cover the evidence, the costs, the practicalities, and where I believe the future might be heading. There are two randomized trials in colorectal surgery and robotics. The first is the ROLARR trial, which also some of you would be familiar with, and this one actually does include Australian patients from Peter Mac. Um, but it was a truly international study with patients from most continents enrolled, and it was published a couple of years ago after a very long period in submission. So it's a multinational RCT comparing laparoscopic and robotic rectal cancer surgery. The primary outcome of the study was conversion to open. I'll go into a little bit as to why that might have been. It's somewhat of an unusual outcome in terms of outcomes, the important outcomes in rectal cancer. 471 patients were randomized, and there was no difference in any of the outcomes measured. There's no difference in conversion, which was the primary outcome, but also no difference in postoperative recovery, whether that's hospital stay, tolerance of diet. There was no difference in oncology, and these were short-term oncological outcomes, like positive margins and TME quality and things. And there was no functional outcome difference either, which I think is quite important. So urinary function and things were no different. The robot was significantly more expensive, about a 1,100 US dollars per case more, and this was statistically significant. There were some limitations of this study. The first is pointed out by the authors and factors into the conclusion, which suggested that the surgeons who were recruiting for the study were at various points in the robotic learning curve, and that they weren't necessarily expert robotic surgeons. There are some centers that had been doing robotic surgery for a long time that did not feel that they had equipoise to randomize for robotic versus laparoscopic. And some of those centers, including MD Anderson, did not think that laparoscopic was the current standard of care for rectal cancer surgery. And also the primary outcome, as well as the comparison group, which is laparoscopic surgery, are probably not ideal in this study. And I'll go into the second component of that a bit later on in the talk. It is important to say, though, that while the surgeons may not have been expert robotic surgeons, this was a trial conducted by robotic surgery enthusiasts. So these were surgeons who embraced robotic surgery and may have been at different time points in the learning curve. The second study was a much more controlled one in a single center. This is the Korean trial of laparoscopic versus robotic surgery. This was published 2 years ago. This was a single center study in a high volume center, the National Cancer Institute in Korea. The primary outcome was more appropriate in this setting. It was the completeness of the total mesorectal excision, and this was a blinded assessment by a pathologist. So they addressed that issue of the primary outcome of the ROLARR trial. It was a smaller study, but very well controlled in one center. All the surgeons were expert robotic surgeons. And again, there was no difference in any of the major outcomes collected. There was one tiny outcome measure of potentially better recovery of sexual function at 12 months, but this was very much an outlier because there were really no other recovery measurements and no reason to explain why this might be. Because of the sheer number of outcomes measured, it's possible that this was just an incidental finding. The robotic operating time was longer. They haven't reported cost, but the expectation is that it's a bit more expensive. Again, the comparison group of laparoscopic rectal cancer surgery is probably not correct, and I'll address that in a minute. The other limitation of this study is this is a very high volume robotic cancer colorectal center, and the patients, as we know, may have different body habitus. The neoadjuvant protocols might be different, so it's unclear if these results can be generalized to the typical Western hospital. Why have I said that the laparoscopic comparison group may be wrong? The reason I think that is purely from an academic scientific point of view. Currently, the standard of care for total mesorectal excision for rectal cancer is actually open surgery, not laparoscopic surgery. And that's because, as of today, the oncological equivalence has not been established. And this is because the two major trials, a la carte and Z6051 from the US and from Australasia, which were designed in the same way, were designed from the outset to try and answer the question, is laparoscopic TME as good as or equivalent to open TME? And both studies failed to show that. And so currently the standard of care, in my view, remains open TME. That includes hybrid rectal cancer surgery. So that's where you mobilize the colon and do the vessels laparoscopically, but do the TME through a lower midline or fan and steel incision. So as long as the TME is done open, I would suggest that that is the current standard of care. And therefore, when a new technology comes about, like robotics or whatever it may be, it should probably be compared to the current standard of care rather than the next step along the chain, which is laparoscopic surgery. It's also important to say that none of the studies which looked at laparoscopic versus open rectal cancer surgery showed any sort of recovery benefit. So the equivalence in terms of oncology was not proven, and there did not appear to be any recovery benefits, and so it's kind of hard to recommend laparoscopic TME as a good option at the moment. So then, why was the robot compared with the laparoscope rather than with open TME? And I really don't know why that is. It's probably because when the two robotic versus lap studies were started, the lap versus open argument was still being answered, and that speaks to one of the dangers of surgical technique research, which is by the time your study is completed and the results are out, the world may have moved on anyway. So what about the costs? We know that from an evidence-based point of view, the benefits do not appear to be that dramatic in terms of patient outcomes, which is what's been measured. The machine itself, the robotic XI costs, this is Australian dollars, just over $3 million. You can get certain concessions and things, but roughly that's how much it costs. There are some accessories that go with it that are probably another $250,000. And then there are ongoing costs. So the maintenance for the robot is about a $200,000 a year annual recurring cost, as well as an additional $3,500 for each case in terms of reusables. You got to remember that the ROLARR trial, it was $1,100 US more for robot versus lap, but that takes into account the fact that you're using often disposable laparoscopic instruments. So, the robotic cost here is in addition to a normal open operation. So it's not cheap. In terms of the practicalities, it seems as though that the cost-benefit equation is not really what's driving the progress in robotic surgery. As far as I'm aware, there are no more RCTs planned, and the RCTs that have not shown a benefit but have shown additional cost have not really made any major difference to practice. Robotic surgery continues to expand, and there are multiple public and private hospitals that continue to invest in robotics and surgeons that continue to pursue robotics. I'm not aware of any colorectal surgeon that is trained in robotic surgery that has stopped doing it, including myself. So why is this? The main reason, I think, is because it is the next step in the technical and technological advancement of abdominal surgery. There is no question that the visibility is improved, the camera technology is better, the camera is fixed and you can hold it and it's not constantly shaking because the assistant's holding it. The articulating instruments are a joy to use, and they allow you easier access. So many of us feel that while the patient's outcomes have not really borne fruit, the operation itself is easier. I certainly find it a lot easier to do a robotic TME than a laparoscopic TME. I don't find it much easier than open, but that's just, I may be one of the few surgeons that will say that. So most surgeons believe that the robotic approach does make the operation easier and more satisfying to perform. There is also the less important aspect, or at least purported to be less important, is that you're sitting down during the case, and so it's less tiring. And it may be that over the lifetime of a surgeon, that doing these cases robotically as opposed to laparoscopically, which again is not the standard of care, means that there's less surgeon fatigue and less RSI type injuries and things. There are other drivers which are less noble, and they include money factors as well as industry level marketing, which has been very effective for this particular device. There's also the thought that this is the first or second generation of robots, and that it's a step along the pathway, and that maybe in the future robotics will have more to offer. And in fact, there may be patient benefits from the technologies coming down the pipeline. And so you've got to start somewhere, and whether it's worth the investment now to secure the gains in the future. It is also possible that once there are more competitors on the market, that the robot becomes cheaper, and so the cost equation becomes less of an issue. So what do we think is coming in the future? Well, we know that both the hardware and software will improve. In terms of the hardware, the next generation of robots is focused on single port surgery, and there's a photo on the top right there which shows this. So it's one big port with multiple instruments through this that can then articulate throughout. Some companies are also working on their robot having independent arms so that it doesn't come down from one boom, but you can actually attach a robotic arm to each port depending on where you want to put the ports. This gives you more flexibility in terms of where you can put the ports, but it also gives you more flexibility in terms of how much robot you buy and use. So you may not need 5 arms, for example. You may be happy with 2 or 3 arms, which will then bring the cost down. It also means that some of the instruments we use in laparoscopy can then be used on the robot, which also will save some costs. And obviously rotating and flexible arms so that they're not rigid. And there's definitely some technologies coming in that area, as well as things like haptic feedback, which is improved. The software is arguably even more exciting. The next robotic systems are likely to offer various software improvements, including the ability to highlight certain organs. You can imagine, for example, if the robotic camera can recognize a ureter, potentially even before you recognize it, and can highlight it for you so that you don't damage it, things like that. Ultimately, it may be that the robots then feed back to improve the surgeon's performance, and down the line, it's possible that we will have autonomous systems that can do the surgery on their own, although I can't see that happening for a number of decades, probably. So the final slide, and I believe the most important one, is, what do I tell the patients, or what will you tell the patients, given what we've heard so far? So I only really do robotic TME or hybrid TME, where most of the operation is done lap and then the TME is done open. In the consenting process, I focus a lot on the TME part, regardless of the approach, because at the end of the day, the surgery on the inside, the most morbid part, is the same. And so I talk about what it means to do a TME and what it means to take out a rectal cancer. I talk about the risks of an anastomotic leak, of ureteric injury, bleeding, lower anterior resection syndrome, sexual dysfunction, all the usual things that should be discussed as part of the consenting process. Once I've finished that, then I spend a bit less time talking about the technique, actually, and I say, look, there's 2 ways I can do this. either open with keyhole instruments for the rest of the surgery or with the robot. There's no difference in outcomes or the quality of the surgery either way. Do you have a preference, or are you happy for me to decide? And I can honestly say that I've never had a patient demand one or the other. Most of the time, if not all of the time the patients will say, look, just do whatever you think is good for this operation. And so what ends up happening in practice is it is dependent on the patient's body habitus, the risks in terms of previous surgery and the anatomy of the disease, but also the convenience in terms of practicalities of having a robot list available. So if it's a patient that I think would be a good candidate for robotic TME and there's a list available within a certain time frame that fits in with neoadjuvant treatment and things, then they'll have the operation done with the robot. If that's not the case, then the patient will have the operation done hybrid or open. And I'm pretty comfortable with this approach. As long as the information is presented objectively and without bias, most patients trust you to do the right thing for them. Thank you very much for listening, and once again, thanks to the organizers for the opportunity to present today.